Dr. Muneeb, please start.
Bismillahirrahmanirrahim. Quote of the day. It always seems impossible until it's done, by Nelson Mandela. Today, my topic of presentation is minerals, which are the iron, magnesium, iodine, and fluoride, uh, by the under the supervision of Professor Dr. Saira Afzal. Now come the iron. Iron is a micro mineral but plays a lot of important roles in the human body. Total body iron content is 3 to 5 gram and 75% of which is in blood. Rest is in liver, bone marrow and minerals. Iron is present in almost all the cells of the body. Now come the iron containing proteins. The iron containing heme proteins are hemoglobin, myoglobin, cytochromes, and iron sulfur proteins are flavoprotein, heme flavoprotein. Iron storage and transport protein are transferrin, lactoferrin, ferritin, and hemosiderin. Now come the recommended dietary allowance for the iron. In the infants till the age of 6 months, 0.27 mg per day iron is required. In the infants of 7 to 12 months, 11 mg per day iron is required. In the children of with age of 1 to 3 years, 7 mg per day iron is required. In the children of 7 to 8 years, 4 to 8 years, 10 mg per day is required. In the children of 9 to 13 years, 8 mg iron per day is required. In the adolescents, the age of 14 to 18 years, in the male, 11 mg per day iron is required, and in the females, 15 mg per day iron is required. In the adults with the age of 19 to 50 years, in male, 8 mg per day iron is required, and in the female, 18 mg per day is required. In the adults older than 51 years, 8 mg iron is required and in the pregnant woman, 27 mg per day iron is required. As I told, in the pregnant woman, 27 mg per day iron is required. It's because the transfer of iron and calcium from mother to fetus occurs mainly in the last trimester of pregnancy. So during this period, mother's food should contain surplus amount of iron and calcium. And in the first 3 months of life, iron intake is negligible because milk is a poor source of iron. So during this time, child is dependent on the iron reserves received from the mother during pregnancy. So that's why in the premature babies, the transplacental transfer of iron might not have taken place. Hence, such babies are at the risk of iron deficiency. After the 3 months of age, diet supplementation and cereals is essential for supplying the iron requirement. These are the sources of iron. In the animal product, there are beef and eggs and chicken liver. And uh, in the chicken liver, there's 9.8 mg per 100 gram iron is present. And in the plant product, there are beans, there are oats, lentil, and spinach and pumpkin seed are the source of rich source of iron. Now come the iron absorption. Iron absorption mainly occurs in the duodenum and jejunum. When the iron stores in the body are depleted, absorption is enhanced, and when the adequate quantity of iron is stored, absorption is decreased. Only ferrous form of iron is absorbed. Ferric form is reduced to ferrous by ferric reductase enzyme, which is present on the surface of enterocytes. And inside the mucosal cell, the ferric ion is complexed with the apoferritin to form the ferritin, and iron in the ferritin is released, then crosses the mucosal cell with the help of transport protein that is called ferroportin. But that can only happen if free transferrin is present in the plasma to bind with the iron. And iron crosses the cell membrane as a ferrous form. In the blood, it is deoxidized to ferric state and transported by the ferritin. Now, the transport of the iron. transport form of iron is transferrin. It is a glycoprotein beta 1 globin with a molecular weight of 76,500 dalton. It is synthesized in liver. Normal plasma level of transferrin is 250 mg per 100 ml. In iron deficiency, this level is increased. One molecule of transferrin can transport 2 ferric atoms. Total iron binding capacity in plasma is 400 mg per 100 ml of blood, and this is provided by the transferrin. One third of this capacity is saturated with iron, and this protein bound iron is about 150 mg per deciliter. In iron deficiency anemia, TIBC is increased, but the serum iron level is reduced. Transferrin has half-life of 7 to 10 days and is useful index of nutritional status. One molecule of transferrin can bind with the 2 ferric ion. Now these are the parameters of iron status. As you can see, the transferrin which is normal 250 mg per deciliter in pregnancy, it increases, and in infection it decreases, same as that of with the serum iron. In serum iron decreases in pregnancy and in the infection. TIBC increases in the pregnancy or decreases in the iron in the infection, and iron stores uh, decreases in pregnancy and remains normal in the infection, but it increases in hemolytic anemia and hemosiderosis. In blood, seroplasmin is the ferroxidase, which oxidizes the ferrous to ferric state, and the apotransferrin plus 2 ferrous ion will change into the transferrin combined with the 2 ferric ion. Now comes the storage of the iron. Storage form of the iron is ferritin, and it is present. It is seen in the intestinal mucosa, liver, spleen, and bone marrow. It can take up to 4,000 iron atoms per molecule. Ferritin contains about 23% of the iron. The second storage form are the aging cells. These cells will release iron with the help of copper-containing protein called hephaestin, which has ferrooxidase activity. And hemosiderosis is also storage form of iron, but it is formed by the partial deproteinization of ferritin by lysosomes and are found as aggregates in the tissues like liver, spleen, and bone marrow. So this is the conservation of iron. When RBC lysis occur, the hemoglobin and haptoglobin complex is formed, and it is taken by the liver Kupffer cells, and the iron is released and which can be reutilized. Then when the globin is removed and the heme is present, heme form a complex with the hemopexin, and when this complex is taken up by the hepatocytes, again the iron is released and it is reutilized. And when the porphyrin is removed from the heme, iron is left, which combined with the transferrin, and it goes for the storage. Again the iron can be reutilized. So here comes the iron deficiency anemia. Anemia is a serious global public health problem that particularly affect the young children and pregnant women. WHO estimates that 42% of the children less than age of 5 and 40% of the pregnant women worldwide are anemic. Anemia results when the hemoglobin level goes less than 12 mg per deciliter. Decreased nutritional intake of iron is the most common cause of iron deficiency anemia. Microscopically, iron deficiency anemia is characterized by microcytic hypochromic erythrocytes. The causes of iron deficiency anemia: decreased intake of iron in the diet, lack of absorption, as if a patient has a surgery of subtotal gastrectomy, or hypochlorhydria. In the hookworm infestation, one hookworm will cause the loss of about 0.3 ml of blood per day. Calculation shows that about 300 worms can produce a loss of about 1% of total body iron per day. Repeated pregnancies, about 1 gram of iron is lost from mother during the delivery, and chronic blood loss, like in the hemorrhoids, peptic ulcer, menorrhagia, and the nephrosis, a patient haptoglobin, hemopexin, and transfusion are lost in the urine, along with the loss of iron and lead poisoning. These are the common symptoms of iron deficiency anemia. It is the shortness of breath, weakness, headache, restless leg syndrome, poor focus, heart palpitation, and fatigue. Lab finding in serum, in the iron deficiency anemia, the serum iron level will decrease, and it can also decrease in the acute and chronic infection, and total iron binding capacity will increase in the iron deficiency anemia, and DIBC also increases in acute hepatitis and pregnancy, and ferritin content is reduced when iron is given in anemia, and the apoferritin production is induced within few hours. Treatment: oral iron supplementation is a treatment of choice. 100 mg of iron plus 500 microgram of folic acid are given to the pregnant woman, and 20 mg of iron plus 100 microgram folic acid to the children. And iron tablets are usually given with vitamin C to prevent it to prevent the conversion of to convert it into the ferrous form for easy absorption. Iron toxicity. More than 50 mg of iron taken orally may cause nausea, diarrhea, and abdominal pain. Hemosiderosis. Iron excess is called hemosiderosis. Hemosiderin pigment are golden brown granules seen in the spleen and liver, and it occurs in hemophilic patient which receives repeated blood transfusion. Hemochromatosis, when total body iron is higher than 25 to 30 grams, hemosiderosis is manifested. In the liver, hemosiderin deposit leads to death of the liver cells and causes cirrhosis. And in pancreas, it causes the death of the pancreatic cell, leading to diabetes. Deposit under the skin causes yellow-brown discoloration, which is called hemochromatosis. And the triad of cirrhosis, hemochromatosis, and diabetes are referred to as bronze diabetes. Treatment of the iron toxicity is the repeated phlebotomy every week till the serum iron and ferritin reaches normal level. And second option is desferroxamine, a chelating agent, form an iron chelate with the ferrous form to form the ferroxamine, which is excreted in the urine. Now come the second mineral, which is the magnesium. Magnesium is the fourth most abundant cation in the body and second most prevalent intracellular cation. Magnesium is mainly seen in intracellular fluid. Total body magnesium is about 25 grams, 60% of which is complex with the calcium in the bones. This mineral play an important role in assisting more than 300 enzymes to carry out in the various chemical reactions in the body, such as building protein, strong bones, and regulating the blood sugar and blood pressure level, and muscle and nerve function. Magnesium also acts as an electrical conductor that contract the muscle and make the heart beat steadily. Recommended dietary allowance of the magnesium for the adults of 19 to 51 years of age is 400 to 420 mg daily for men and 310 to 320 mg for women. Pregnancy requires about 350 to 360 mg daily, and lactation requires 310 to 320 mg daily. The normal serum magnesium is about 1.6 to 2.5 mg per deciliter. Inside the RBC, magnesium content is 5 micro equivalent per liter. In the muscle tissue, magnesium is 20 milliequivalent per liter. Uh, Homeostasis of the magnesium is maintained by intestinal absorption as well as the loop of Henle of the kidney. Now the functions, magnesium is the activator of many enzymes requiring ATP. which are the alkaline phosphatase, hexokinase, fructokinase, phosphofructokinase, adenylyl cyclase, cyclic AMP, dependent kinase. All of these enzymes requires magnesium, and neuromuscular irritability is lowered by magnesium. In insulin dependency, insulin dependent uptake of glucose is reduced in magnesium deficiency. So magnesium supplementation will improve the glucose tolerance. Now come the hypomagnesemia. Serum magnesium level below the 1.7 mg per deciliter, it is called hypomagnesemia. The causes are increased urinary loss, hyperaldosteronism, familial hypomagnesemia, increased intestinal loss through diarrhea, and laxative ulcerative colitis, nasogastric suctioning and vomiting, and in the liver cirrhosis, malabsorption, protein calorie malformation, and hypoparathyroidism, toxemia of the pregnancy, and in the drugs. Okay. Signs and symptoms of hypomagnesemia is the clinical manifestation includes anorexia, nausea, vomiting, lethargy, weakness, personality change, tremors, and muscle fasciculation. And it also show the positive or joustic sign. Treating the underlying cause of the hypomagnesemia will normalize the magnesium level. Hypermagnesemia. The causes of hypermagnesemia is the excess intake orally, or the renal failure, hyperparathyroidism, oxalate poisoning, rickets, multiple myeloma, dehydration, and the drugs like antacids and tacrolimus. Signs and symptoms of hypermagnesemia is a nausea, vomiting, neurological impairment, abnormally low blood pressure, flushing, and headache. Again, the treatment of hypermagnesemia will be the treatment the underlying cause will normalize the serum magnesium level. The third mineral is the iodine. Iodine helps make the thyroid hormone, which help to keep the cells and metabolic rate healthy. Adults need 140 microgram of iodine a day, 220 and 290 mcg daily for pregnant and lactating women, respectively. Total body contain about 15 to 20 microgram of iodine. All cells do contain iodine, but 80% of total is stored in the thyroid gland. Iodine level in the blood is 5 to 10 microgram per deciliter. The only biological role of iodine is in the formation of the thyroid hormone, which are T3 and T4. So these are the sources, food sources of the iodine that are in the dietary products. Milk, yogurt, cheese are the best source. Seaweed loaded with the antioxidant, iodine, tyrosine, and vitamins. And prawns are overpowered with the vitamin A, K, potassium, and iodine. Eggs are the high on protein, uh, healthy fat, vitamin, and iodine. And iodized salt is a strong source of iodine. Now come the thyroid hormone synthesis, role of iodine in the formation of thyroid hormones. First of all, the iodine uptake is done by the thyroid cells. Then the oxidation of the iodine is done in the thyroid cell with the help of HMP shunt pathway. Then iodinization of thyroglobulin is done, and the formation of monoiodothyronine and diiodothyronine occurs. Then the coupling occurs where the monoiodothyronine and diiodothyronine will combine with each other to form the triiodothyronine and tetraiodothyronine. And then in the last step, the T4 is liberated by hydrolysis by specific protease, and this hydrolysis is depressed by the iodide. That's why potassium iodide is used as an adjuvant in the hyperthyroidism treatment. Now, the deficiency of the iodine can lead to the hypothyroidism. It is more common in the iodine deficient areas of Pakistan, like Khyber Pakhtunkhwa, Naran, Balakot, and Hazara. And silent symptoms of hypothyroidism are the fatigue, lethargy, weakness, sensitivity to cold, constipation, dry skin and hairs, and weight gain. Lab finding will be decreased free T3 and T4 level and increased TSH level. Treatment can be the iodine supplementation and thyroxine. Uh, in the toxicity of the iodine will lead to the hyperthyroidism. Signs symptoms of hyperthyroidism is the weight loss, fast and irregular heartbeat, hand tremors, irritability, fatigue, and sweatiness. Lab finding will be increased level of free T3 and T4 and decreased level of TSH. The treatment will be the anti-thyroid drugs. Now is the fourth mineral, which is fluoride. Fluoride is known to prevent the caries. The caries is a Latin term meaning the decay. In the pits and features of premolar and molar teeth, bacterial fermentation of the residual food leads to acid production, and this acid removes enamel and dentine to expose the pulp, leading to inflammation and toothache. Topical application of fluoride will result in the formation of fluoroapatite, which layers on the enamel and protect the enamel from the decay by acid. The safe limit of the fluoride is about 1 parts per million in water. And fluorosis, the fluoride level more than 2 parts per million will cause chronic intestinal uptake and gastroenteritis and loss of appetite and loss of weight. Level more than 5 parts per million will cause the mottling of enamel and stratification and discoloration of the teeth, and a level more than 20 is toxic, leading to alternate areas of osteoporosis and osteosclerosis with brittle bones. This is called fluorosis. And genu valgum is the characteristic feature of fluorosis. And just a fluoride accumulates in the bone and it is a cumulative toxin. Now come the recent updates. The iron deficiency anemia. This is the article with the title of iron deficiency anemia in the women of reproductive age in urban areas of Quetta district of Pakistan, and it was published in 2022. The main features of this article, it was a cross-sectional study and was conducted in the urban area of Quetta city among the women of reproductive age 15 to 49 years of age to update the status of iron deficiency anemia in the region. Overall, 75% of females were non-anemic, and among those that were anemic, 2% were severe, 13% were moderately, and 10% were mildly anemic. Among the iron deficiency affected women, 83% were pregnant. The highest number of moderately affected iron deficiency anemic women, 15% were in the age group of 15 to 19. And this strategy will be beneficial for illustrating the requirement and the development of a program to raise the extended awareness in the Quetta community to overcome the negative health effects of iron deficiency anemia in the female population. This is the second article showing the factor affecting the consumption of iodized salt by the pregnant women in the study. It was also published in 2022. The main points were the pregnant woman of a total sample size of 360 visiting the antenatal OPD at the public sector tertiary care hospital of Karachi were interviewed using structured questionnaire, and result shows that 31% of pregnant women were consuming iodized salt in their homes. Percentage of participants who heard about the iodized salt for the first time was 24%, and that 12% reported that price of iodized salt is more than that of normal, and 98% of the pregnant women replied that they were not informed about the importance of iodine or iodine requirement during pregnancy by their doctor or healthcare provider. Conclusion shows that the low education, low income Uh, and of the study participants are identified as the factor related to limited consumption and incorrect practices related to the use of iodized salt. And there is also immense need of support from the government side as well to make the strategies and policy changes at the national level to ensure the availability, accessibility, and affordability of iodized salt. Now it's the time for MCQs. MCQ number one. Patient XYZ, 21 years of age, presented in the OPD in hospital with a complaint of shortness of breath, generalized weakness, headache, fatigue. On examination, patient was paler, and lab finding shows HP level on the lower side 8, and low serum iron and ferritin level, and increased TIBC. On microscopic examination, erythrocyte shows microcytic hypochromic picture. What is the most probable diagnosis?
C.
Yes, C is the right answer. Anemia due to iron deficiency. Answer number two, patient XYZ presented in the OPD and was diagnosed with iron deficiency anemia. Patient gave the history of some abdominal surgery, which remained successful with no history of blood loss 3 months back. Now, what can be the cause of iron deficiency anemia? Laparotomy, subtotal
Beta.
gastrectomy, open. Yes, it's beta subtotal gastrectomy. Question number three. Patient XYZ, a known case of hemophilia presented in the OPD with a complaint of polydipsia, yellowish discoloration of the skin, and there was abdominal ascites on examination. HbA1c was raised. What is the most probable diagnosis? Uh, A is the diabetes mellitus, B is the Brown's disease, C is the chronic renal failure, D is the SLE.
Alpha.
It's beta Brown's disease. Question number four, patient XYZ presented in the OPD with a complaint of anorexia, nausea, vomiting, lethargy, weakness, and personality change. Patient gave history of diarrhea for last 1 week. On examination, Troso and Chowstick sign was positive. What can be the cause of his presentation other than hypocalcemia? A is hypomagnesemia, B is hypermagnesemia, C is hypokalemia, D is hyperkalemia.
A.
A, it's A, hypomagnesemia. Question number five is patient presented in ER with a complaint of vomiting, neurological impairment, headache, and hypotension. Patient has a history of oxalate poisoning. What is the most probable cause of his presentation? A is hypomagnesemia, B is hypermagnesemia, C is hypernatremia, D is hyperphosphatemia.
D.
It's actually B. B, hypermagnesemia. Question number six, patient, a resident of Balakot, presented in the OPD with a complaint of lethargy, weakness, sensitivity to cold, constipation, dry skin, hairs, and weight gain. Consultant told that it's hypothyroidism. What will be the lab findings? A is increased T4 and T3 and increased TSH. B is increased T4, decreased T3 and increased TSH. C is decreased T4, decreased T3 and increased TSH. Delta is decreased T4, increased T3 and increased TSH.
C. Charlie.
Yeah, yes, the answer is C, decreased T3 and T4 and increased TSH. Question number seven. Patient presented in the OPD with a complaint of weight loss, palpitation, hand tremor, lab finding show increased level of T3 and T4 and decreased TSH. What is the most probable diagnosis?
B.
Yes, it's hyperthyroidism. Question number eight. 2 ppm of fluoride in the blood will cause intestinal upset and loss of weight. What will be the level of fluoride which can cause mottling of enamel and discoloration of teeth? A
C.
is yes, it's C 5 ppm. Question number 9. An 11-year-old age boy presented in OPD with a complaint of change in gait pattern. He gave history of eating toothpaste accidentally few days ago, and it was diagnosed as a case of fluorosis. What is the characteristic feature of fluorosis which changes the gait? Alpha is
A.
genoval. Yes, its answer is alpha genovalgum. Question number 10. To know the factor affecting the usage of iodine salt by the pregnant woman in Karachi, 360 women were interviewed using questionnaire. What was the percentage of women reported that was not informed about the importance of iodine intake during pregnancy? A is 30%, B is
B.
50%, C is 60%, D is 98%.
D.
Yes, your answer is D, 98%. This is the key, and thank you.
Okay, thank you very much. Very nice presentation, Dr. Muneeb. The important thing is that MCQs must have 5 options, and that is one of the standard that we have set in our presentation. The second important thing is when we are discussing at postgraduate level, there are other things that must be mentioned. For example, the low ferritin levels. The low ferritin levels, as you have described, that they are associated with iron deficiency. There are also the chances of finding high